So it's my pleasure to introduce you to Dr. Bernice Coleman. She's a nurse scientist, a fellow of the American Academy of Nursing, and she has 31 years of advanced practice nursing experience. She is a board-certified acute care nurse practitioner working in the heart transplantation and ventricular assist programs at Cedars-Sinai Medical Center in Los Angeles. She wins the prize for coming the longest distance and taking the red eye on Friday to be with us, so we're grateful for that. She holds a bachelor's degree in nursing from the University of Bridgeport, a master's of science from Yale School of Nursing, and a PhD from the UCLA School of Nursing. She completed 2 postdoctoral experiences, one in the histocompatibility laboratory at Cedars-Sinai Medical Center, and the other at the NINR Summer Genetics Institute. Her bench-to-bedside research focuses on exploring ethnic genetic differences between African Americans and Caucasian Americans after heart transplantation. Her current study, a genome-wide association study exploring heart transplant outcomes in African American and Caucasian American heart transplant recipients, is nearing completed. The study was funded by the NIH and the Clinical and Translational Science Institute at UCLA. She has also made strong contributions to nursing through her leadership in various organizations. Most notably, she's a past member of the American Heart Association Leadership Council on Cardiovascular and Stroke Nursing, past chairperson for Nursing Health Science and allied council of the International Society of Heart and Lung Transplantation, and a member of the nominating committee for the International Society of Nurses in Genetics. She is currently a member of the U.S. Department of Health and Human Services Advisory Committee on Organ Transplantation, and her talk is entitled Minorities in Transplantation, Are the Outcomes Equal? Bernie, it's a pleasure to welcome you back to Yale, and I look forward to you.
Happy to be home. Okay, I have no pockets. I am caffeinated. I am standing after traveling for hours, but here I am. So thank you very much for this invitation to come back to Yale. I'm always excited to be with my best friend Marge and to be back home. This talk today is interesting, and it dovetails nicely Dr. Hinshaw's talk this morning, and I was sitting there thinking, oh, so I could be affecting policy. Isn't that interesting? Because heart transplantation's been around for a while, and everybody knows that it's the definitive kind of, with the big quotes, treatment for really nasty end-stage heart disease that's no longer responding to medical management. And there's a lot of data out there, obviously, that says it's a good choice, and sometimes it's the only choice for some patients, but not for everybody. And so I've been very active in the International Society of Heart Lung Transplant from the nursing leadership, social science leadership part, and also for contributions to presentations. And that particular organization is about the business of organizing all of the transplant programs across the world, across the globe. What's interesting is, as I started looking at my curious questions, there's a huge database of over 180,000 transplant patients, which is amazing. And there is no variable called ethnicity. Oh, I'll repeat that. There is no variable called ethnicity. So there's a small renegade group for which this alum is part of, who has set out about the business of pushing the envelope and doing some serious face work with the leadership of the International Society to say, you've got to add ethnicity and or race to your database. You have to. You can't start recruiting around the world and throw everybody into the pot and homogenize us, everybody, and say, these are the best practices for transplantation. So that's how this absolute brand new sort of spin is happening right now. And we have a draft of the first paper to go into our journal around this issue of ethnicity, which is crazy in transplantation. I know, you can't believe it. I can't even. So what I thought we'd talk about, and I could talk forever, so I'm going to try to keep myself focused, and I'm just going to talk about survival, and maybe you'll have a lot of questions that I would not have answered in this talk, and that'll be good, but I got to stay on time. I know that, because you can get a hook. So I'm just going to talk about survival as it looks, as we focus on African Americans and Caucasians, and then you'll see why in a minute. And then this thing called induction therapy. So I'm going to do just a teeny bit of science. I think if I didn't, we were talking about cutting out slides this morning. If I didn't cut the slide, I can't remember if I did or not. So what started this? Well, so I'm a practitioner, and all my questions come from practice, and my research makes sense to me because I can translate it back to patients, and I can try to impact patients. So this is a picture of our transplant team probably in 1990. We were a very small team. And it's not a team, but it's our patients. Transplant patients in 1990, we were a very small program. And every year we have a big Christmas party and we take a picture. The patients gather together in a corner and take a picture. And it's always a great year because as clinicians we get to see them dressed in their clothes and they bring their family and it's fabulous. And they thank us and we love it and it's a beautiful Christmas. But the question in my head always was, every year when we do this again, when this group comes back, patients will be missing. And it's likely the missing patients are the African Americans. They're dead. So we give them the same protocols, we treat them the same way, but they don't have the same survival. So that was my curious question that was driving me. So just looking a little bit at stats, this is from September, there's something like 20,000 people that are waiting on the United network of organ sharing, which is the obligatory repository that every transplant center has to register every patient in. And so there's about 120,000 people waiting for all kinds of organ transplants. But if we look specifically at heart transplants, there's just a little under 4,000 heart transplant patient waiting. And at that time, there were like 436 in California that were waiting of that 4,000. And in California, there are 21 transplant centers. So we are Region 5. Our center did 119 transplants, which makes us actually the largest transplant center in the U.S. and certainly the largest transplant center last year across the globe. So we're pretty big. If we look at survival, and these data come from the UNOS database, this is impressive that I could use this and not do this. Part of my caffeine. See, Margaret? Very good. All right. I get 2 points. Okay, so if we look at these groups look pretty much similar. I mean, there's detriment. But the African Americans continue at a faster rate to not enjoy the same survival. So it just validates kind of what my sense was. So in transplantation, it's all about the medicines. How well patients take the medicines, how well we choose what medicines patients should get, how we try to balance the kinds of medicines they get to prevent opportunistic diseases because we're manipulating their immune system. And this is what patients see. Yeah? It's crazy. So we did a little study inside in the hospital, just curious to see how well nurses were following the prescriptions of following all the orders to the patients that they should get. Some patients get up to 40 doses of medicine a day. And then we send them home because God knows they can't stay in the hospital too long, right? Now, this is not going to be what you think it is. Okay, it's not, honestly. What I wanted to put this, and let me just hit this so all the little last pieces come together. Okay, fine. So what's important here is that from an immunologic standpoint, there are 3 signals that we're trying to prevent with all of these kinds of medicines, and why they have to be timed when they're supposed to be, and why patients shouldn't skip them. And that's just generally, that doesn't really speak to the individual's immune response or the genetic load that they're carrying. It's just kind of like the broad concept. But in a minute, I'm going to be speaking about some multisyllabic medicines. And this one is Thymoglobulin, and I don't really see basiliximab there. But one of the things that basiliximab does is it is going to be working over here on this 3rd signal. So we have 3 signals. Here we go, signal 1, 2, and 3. So see that wasn't really painful. Don't worry about all the middle of this because we already saw those meds that take care of this, and that's enough talk. So if we think about transplantation, and then I was thinking, you know, it could be boring if you don't have pictures. So I thought I would put Lynn. It's very nice that you came, but I wanted to make sure you stayed awake with me. So think about transplantation, because this is what it is. It's transplanting foreign genetic material into an immune competent system, meaning that the thymus made some very educated T cells, of which 95% of them did not pass their PhD in the thymus, and they were killed. So the 5% that are circulating do the job really well. And so we, the human beings, decided that we could trick those cells and we would give them some genetic tissues, and so that's why we have all those medicines. So all of these patients might receive induction, followed by this triple medications, which we don't have to go over. But the thing that's important is that the drug regimen has historically been chosen by organ. So by consensus, abstractly, a bunch of folks read the literature and said, these are the best drugs. So we're still missing the point because you're giving them to me. The best drugs for who is really the question. So again, I'm not going to make you crazy, but I think the visuals are nice. If you think that these are T cells, and they're stuck to the inside of the blood vessel, they're going to be anastomosed recipient to donor. So here's yet another picture. So this is going to be direct allo recognition. This little suture line is where that anastomosis happens. These T cells are the D for donor, and they're the different kinds of sorry about my brain. Maybe there's something in this space, because you were having trouble with names earlier. So these are CD4s and CD8s, but none of that's important. It's just that here's the suture line, here's the recipient, and along with that brand new heart, you're also bringing some stuff over from that other person. Okay, and this is our recipient. So there's our donor, there's the recipient, here's the important antigen-presenting cell, and here is the recipient's T cell that says, I see that this is foreign, and I also see that you've got a piece of peptide right there, and I'm going to attach to that because that is foreign. And as a matter of fact, this is the reason why I have this slide here. Here are some cytokines, and the rest of the data that comes forward, I'm going to show you, is about these 2 cytokines. So these are inflammatory cytokines. And that's a memory cell up there. It's a nice one. It's actually involved in this war, and it created a receptor antibody that's specific to that particular antigen, so that when it sees it again, or you kind of forget your medicines, then we'll just start this rejection process. So that was good? Kind of like background. Okay, so in my first postdoc, I was interested in looking at cytokine gene polymorphism. So I was looking at some of the genetics, because we were thinking that those little IL-2s, IL-6 and TNF-alpha, who are mediators in that process, are the genes the same? And no, they're not. So here, these are the African Americans, and these are the Caucasians. So the first thing we discovered was IL-6GG, this genotype, was greater in African Americans. And then when we looked at TNF-alpha, and we all know TNF-alpha, it's fundamentally the mediator of fever and a whole bunch of stuff, this TNF-alpha GG in African Americans was pretty high. So when we put those two genotypes together, lo and behold, right around here, everybody looks the same, but then these curves diverge and they just keep going, and you saw that data already. And so clearly there was a difference. And so these genotypes were interesting, and we know, this is way back in the mid-2000s, so we know that it's not just the genotypes, but it just happened to be the two that I was studying. I was next interested in, but what about rejection? Is this, because in the early times, in that picture you saw, people were dying of rejection. Do they have the same kinds of rejection? Now for us, anything greater than a 1B, which is, 1B, and then a 2, and then a 3, as you go up it gets worse, that's treatable. Was there a difference? And there was a really big difference in these African Americans with the 1B, but this is really the one. Now forget the stats, forget the standard deviation, forget the fact that you don't see significance. None of that's important. What's important in this slide was here are the biopsy grades, A, 1A, 1B, 3A, 3B. Here are the ethnic groups. Here are the days from transplant to positive biopsy. If you're African American, 1As we don't treat, but in about 60 days, you're going to have a 1A. If you're Caucasian, 187 days, you're going to have a 1A. Something's really different here. Okay, here's the worst kind, 3B, 3A. If you're an African American, about 134 days, you're going to get one of these. But look what happens if you're Caucasian. That's freedom from. That's amazing. Something is really, really different. So I was like, wow, that was a big wow. So we know that the cytokines are different. We know that the rejection pattern, which is for us, the outcome is different. There was a lot of question in the literature. Maybe the real problem is that African Americans shouldn't get Caucasian hearts. Now, conceptually, don't hurt yourself. What? I know. And even in the world we live in, these questions are being asked. They're still being asked as recent as a few months ago when I looked at infant data. One of my esteemed colleagues said, Bernie, do you have the donor data? Because you really need to know if the babies, if Caucasian babies donors are being given to African American babies. And I'm just kind of looking at it. Really? Because this phenotype is not my genotype at all. And you have no idea, actually, who I really am. I do know. Anyway, what we know from this paper, and this is a very large cohort, look at that number, it's to bed. Okay, let's put it to bed. The race matching, who people self-report to say who they are, not relevant. What we do know is that, again, this is from CIRC, a very large population, again, of over 2,000 patients. What we know is that from the early times to the current times, everybody's getting better, but the disparity remains. That's basically what this paper's saying. So the question that I had was, well, maybe it's induction. Because if the T cells are really smart, and we give them genetic tissue that is foreign, and there seems to be something going on with this African American immune system that seems to be hyperreactive. I mean, it's just really going crazy. If it seems like if these folks miss their dose when they're not supposed to take it, then they may have worse consequences. So I wondered, okay, so what about if we give induction to this group? Does it help at all? Well, the real problem is you can't ask that question of your own transplant population, even though we're very, very big. I mean, we do the most transplants, because the truth of the matter is that the numbers of African Americans in the transplant database are probably going to mirror the numbers in the U.S., about 12%, about 13%, not enough to really get a handle. So I ended up looking at a larger database, but just by way of definition, induction basically is the giving of a drug that basically is going to confuse the patient's innate T cells. So in that first animated picture where we had the 2 donor T cells and then the recipient came in, with induction, that it's not likely that the recipient T cell goes in, or if it does go in, it doesn't have the affinity to bind to that receptor site. In other words, the bottom line is it doesn't activate the immune system. So it gives the organ time to get acclimated. It gives the immune system time to get acclimated. And Thymoglobulin is one of the drugs that you'll see in a minute. And it basically confuses the T cells for about 180 days. And the biggest time for rejection is the early time that the organ is transplanted. So the principles here would be, number one, the immune reactivity is the highest in the early time. And it allows for a number of medications to be used, not in high doses, to decrease the toxicity. And we would like to avoid over immunosuppression because of infection and malignancy. And so that's kind of why we do it. But the bottom line is that induction therapy is actually the religion of transplantation. You either believe it with every cell in your body, or you reject it with the same power. Now, there's a middle group coming that says, maybe it's not so bad for some people, but we think that some people are the highly sensitized people, besides the ethnicity. It's really the highly sensitized people. What does that mean? That means that the people who have a lot of antibody to the general public. If you've got a lot of antibody to the general public, the possibility of finding an organ that's good for you, very low. So maybe those people should, despite who they are, and mysteriously the largest number are African Americans, so despite who they are, they should get induction. So that's kind of where we are. Now, it's very controversial. But despite the controversy, 50% of the transplant programs really across the globe use induction. So my question was, I wondered if induction might confer some benefit for the African Americans. So we already know the advantage. A lot of African Americans who come to transplant come with a different disease. They're not coming with dilated cardiomyopathy. They're typically coming with hypertensive cardiomyopathy. And they may also have diabetes. So their kidneys, they go into this story with not the bestest kidneys. So one of the things that induction does is it allows you to not amp up the calcineurin inhibitor, which is the mainstay of the drug, tacrolimus. You can hold back and start very low. And given that the kidneys already had a hit in the operating room because we put it on cardiopulmonary bypass, that would be a good thing. And so it'll kind of get them over the hump of the worst part of the transplant process. So induction seems like a good idea. And African American heart transplant patients have been reported to have this higher incidence of rejection, which we know for sure. And again, this role in African Americans have really not been established. Because why? Because we don't use ethnicity in our database. How would we know? So I looked at the UNOS database, and I looked at 11,000 patients. And so what this is, and this morning the arrows would not work for me, so I apologize if the arrows aren't on here. But the straight red line are Caucasians who receive thymoglobulin. And the dotted line are those that did not. And the straight blue line are African Americans that receive thymo, which is 451. That's a lot of African Americans in our world because there's no place to get that number. And this dotted line are African Americans that did not. So right off the bat, what you can see is that when you look at the African Americans, the blue lines, and compare them to the red lines, they do worse than the Caucasians. But when you look at the African Americans here, you see that there looks to be something that looks like maybe induction might be a good thing for them versus this group that got no induction. So we wondered, because the immune system changes as we get older. So we wondered, was that the same across age? And here what we did was we looked at some of the, two of the major medicines that are used for induction. This is ATG, or Thymoglobulin, that you saw in the animated slide, and this is basiliximab. They have different mechanisms. This one really kind of punches the T cells in the nose and gets them all confused, and I don't know where they are. I don't know if they stay in the lymph nodes or what they do, but they're very, very confused for about 180 days. This guy actually competes with one of the co-stimulatory molecules, but it doesn't stay tightly affixed. So it allows the immune process to happen, but it slows it down and makes it a little bit not as strong. This one is kind of like Drano. It's like does the job, period. Okay? So here we have Thymo, and in this group, if you're African Americans within this group and you get Thymo, your survival clearly looks better. If you get basiliximab, looks like not so good in this group, age group. If we look at African Americans who are age 60, this is what they need. They do not need this. What does this do? This kills them. Yeah. These data are totally brand new. It's pretty crazy. And for all of us, now you guys are not transplanters, I bet you get it. So we're hoping that in my community, where we do this all the time, they get it. But I can tell you what the answer is, but there's no randomized controlled trials. That's the constant answer. It's interesting. But I think we have some outside forces that are pushing this right now. So clearly age is important, and why is it important? Because this drug is too strong for this immune system. It actually is killing patients. Oh, look how, I guess I really chopped some stuff out. Because I had some baby data that looks really the same. I was curious, and I'll just say this few things before I summarize. So I was curious after looking at this year. I have nothing to do with children. I had one, I have some grandchildren. But I don't take care of babies, I would just cry. But I did have the data, so I thought I'd look at it. And I looked at 0 to 2, because that group, this has nothing to do with them deciding to take a holiday. It's us. We give them the medicines. And it is very clear that in African American babies in that age group, if they get Thymoglobulin, they do well. And in Caucasian babies, as in the Caucasian adults, it matters not if they get induction or what they get. But for these babies, it's really, really important. And so once again, it argues for an immune system that is different in this group than other groups, likely very, very hyper reactive. And I think that we are in a place in transplantation where this kind of research has to get done. Because as you aptly said about the policymakers and what happened with Mary Naylor, it got written right in. And if you look at the data right now about should you induce or should you not induce, induction is really the word, we should not use the word induce, right? Should you use induction or not use induction, the data, it depends on who you look at, would say absolutely not, not good, not founded, no randomized controlled trials, etc. And therefore induction would not be useful. But that's not the case, because the outside forces that are going to change this are the switch to population health. And the issues that hospitals have to really show that patients, by populations, are doing good or equally good. And so there's going to be a need for wanting to know around the issues, the broad issues of ethnic groups, what's best for them, and the specifics of the individual, despite the ethnic group, what's good for you? Because that's the question you're going to ask when it's your turn to be ill, no matter what the issue is. What's good for me? So I think the areas for nursing research are gigantic, very, very exciting, and unbelievably critical. Because it's a nurse asking these questions. And a month ago, when I had to take a podium with a standing room only because they piled in to find out, because these are surgeons and cardiologists who are caring for babies, and none of them looked at this data. It's amazing. It's out there. And I had to talk about this data. I could talk about the data, but if they started the specifics of what do you do with whatever, I had a bunch of plants in the office, in the audience, and I get close to the mic because I'm going to say, excellent question. Dr. Patel, would you answer that? And I don't want to have to do anything with babies, but on the issue of the science, something, if you look at the theme is there's a difference in this population. What is it? I don't know. And I'll just stop because I chopped out a lot of slides and we have time for a lot of talking. That's good. Yes.
If the data about race wasn't collected, how could you even do this research?
Oh, because this data comes from the UNOS database. And the UNOS database is an obligatory database that if you're going to be a transplant center, you must register every single patient and you must answer every question that we ask you. So UNOS, yeah, UNOS has race and it has follow-up and it has everything. But the transplanting world looks at databases, not so good. Like, there's obviously issues with retrospective databases, missing data, et cetera. But we found enough numbers to give us a signal, using the terms that people like to use, that say there is something there. And we need it. We owe it to ourselves and we owe it to the patients. Because I have many patients, but one that sticks. How much time do I have, Margaret, before I go long?
Got about 8 minutes.
Okay, good. I won't do bad. I have a patient, I told this story last night. It's an African-American female. She's 40-ish. She's transplanted. She had hypertensive cardiomyopathy, and she gets a heart transplant, which is a big deal for an African-American female because she's highly sensitized. So with each pregnancy, she gets to meet the husband's antigen, and she builds antibody. So she gets desensitized, she gets transplanted, and she really pays attention to exactly what her doctor said, which was, these are your side effects. Let me know if any of this happens. Contact the transplant center. She did all those things. She became a pain, a major pain. That's a difficult patient because she wasn't a 5-minute visit. She came with a list, and she said, okay, but every time I take this, this happens. And when this happens, this happens. What should I do about this? I'm really worried about this. Look, we told you to do so-and-so. I'm calling up because I'm having this and I'm having this. So what does her doc do? Now, they didn't, this is a Kaiser group, so we get a lot of Kaiser patients. And once we get them over the initial recovery, they go back to Kaiser to be managed. And we don't hear any more from Kaiser unless there are issues, et cetera. So Kaiser's managing the patient. The doctor decides to take her off all of the regimen, put her on a different regimen, just to shut her up and stop the side effects. This is going to be better. So he puts her actually on a suboptimal regimen. She now shows up in the ED. I can't breathe. I can't breathe. So they admit her, and sure enough, her heart's this big on X-ray. And they go to biopsy her, and she biopsies as a 1B, which we saw over there, which is kind of, usually we just give a steroid bolus. But she's looking really sick. So she continues to get sick, and they throw on some inotropic medicines to help that heart work some more. And and put a balloon in, and she's not doing well, so we now get a call. And they're like, we got a turf to you, she's going down the drain. She comes to us, we put her on ECMO because she's really bad. But as I was saying on the phone, as soon as she got on ECMO and we could offload the heart, which clearly wasn't working, she's on the phone talking, she's managing her house, she's doing whatever, she's doing great. But she's not well, and her heart's not well, so we end up having to put a ventricular assist device in her. But in the operating room, in order to get the hoses into the ventricles, you basically pull up the ventricle, core it with an apple corer, take a plug out, put the hoses in, and so all of that tissue goes to cath, and that's where we found the 3B. So biopsy, you know, is random. They drop it in, you blindly take a snip, and you hope you hit it right, but it could be happening somewhere else. So she has really bad rejection. And we treat her. The story turns out to be a good story. I won't bore you with all the bad parts of it, but I'm sitting in a room and I'm talking to her. And again, we're on rounds, and mysteriously enough, it's the same doctor that asked me to make sure that I know about the donor and recipient donors thing. So he says to me, is she taking her medicine? Because we're giving her medicines, and we get a TAC level every day, and it's still so low. I said, Jamie, she's taking her medicine. Yes. She is a high metabolizer. What do we not do? We do not genotype. I do have them genotyping for Coumadin, so we genotype for Coumadin for AVAD patients, but we don't genotype for tacrolimus, which we need to. It's just the genes are just beginning to get explicated. So again, when it comes to individualizing care, that's what we're going to have. That's what the future is. The future is completely permeated with genetics and individualized care for all of us. And it's complicated. It's not going to be easy. It's not, you're speaking about science. I don't know why genetics didn't just sit by itself as an INR priority, because it is, because it's going to be the underpinnings of everything. One of the beauties of the AIDS epidemic, if there's always a silver lining, it was the AIDS epidemic that brought immunology into nursing. And it's the underpinning of all of transplantation, and genetics is the underpinning of everything else. You have to ask more questions, so I'll just keep talking. Yes.
Thank you for answering my question. That's exactly where I was going in terms of genetic. And as you said, this phenotype does not represent your genotype.
Right.
And that at some level we need to link with genetics, both at the NIR,
Absolutely.
as well as in our individual research, because that is going to be.
We have to add that person to our team. It doesn't matter what we're looking at. Just bring in somebody who knows genetics, and bring in a genetic statistician. Look at UAB. UAB has got a huge training center just for the discipline of genetics, statistics and genetics, because it's gigantic. You have a question?
So, are there any disparities like this in LVADs? Has anyone looked at that? Would there be any reason why there should be differences based on ethnicity or race in LVADs?
So in the LVAD, that's a good question, and I think the biggest issue for ventricular assist devices, because unfortunately we have moved past the LVAD word, because now we do total hearts. So we actually are one of the...
MCS.
Yeah, that's right.
No big deal.
That's right. That's our new one, MCS, Mechanical Support Systems. The biggest issue with mechanical support is the notion of anticoagulation and what is the right dosage for anticoagulation. So before we put these machines in people, and we could just go on forever of the interface between machines and people in somebody's house, requiring electricity 24/7. So for NINR, they got a lot of future stuff that needs to get on that list, because there's going to be so much of that. It really is the anticoagulation, and so the use of warfarin, which is the mainstay, or rat poisoning, yes, and the dosing and the balance there. So you want to get the right balance so you don't over with a little hypertension cause a nasty stroke, or under and clog up the $200,000 device and or kill the patient. So that's a tough balance. And I think where we're looking is we are looking at the genetics of that, and it does aggregate by ethnic group. For example, in the Asian population, you would just want to give just a touch of warfarin. Just start with a milligram. I've had a patient with the hematologist literally holding my hand. I said, "Do you really want me to write this?" And she said, "Write it." 11 milligrams of Coumadin. And I still couldn't. We were just getting up to the dose where we wanted to get a little over 2. So clearly it's the genes. And so we do genotype.
But you say it's much more common to do that in Coumadin in MCSD than it is in transplant.
Yes.
It seems odd.
Well, it does seem odd, except anticoagulation is to MCS as immunosuppression is to transplantation. And MCS is kind of new relative to right transplantation. I'm just speaking about hearts for a second, but kidneys were older than hearts. Uh-oh, she's standing. I saw it. So I think it's just a matter of age.